Greetings, I'm Dr. Kim Yongjin. We provide implant treatment to deliver ideal prosthesis on the alveolar bone. For ideal prosthesis, you need to place the implant well. How can you place implant well? There can be many different ways, but as of late, the most popular is the digital guided surgery. When digital guided surgery is used, even beginners can place implants in good position and good depths, and that is the cause of its rising popularity. However, if you use digital guided surgery without knowledge, there can be many complications. If you know the cause and reasons behind these complications, you'll be able to avoid that. In this lecture, I'm going to talk about most notable complications related to digital guided surgery. First, when you do digital guided surgery, implant placement is not done as planned if you just drill on the hole in the guide. In some cases, implants can be placed easily, but in other cases, there can be different variations and the unknown. First, the implant can go in the different angulation path than anticipated, and this can be experienced frequently in free-end cases. So guide is supported in the front area with natural teeth, and in the posterior area, if there's no teeth, this is a free end case. As you do drilling, you tend to press upon the guide, leading to tension in the gingiva below that supports the guide. Because of the elasticity of gingiva, if you drill through the guide will be twisted. Think of the fish and its tail, for instance. Even if you move in the same angle, the closer you get to the tip of the tail, the more the amount of deviation is. Likewise, the more distal you get away from the tooth support in the frontal area, you get more deviation. Deviation in drilling occurs, and the implants that are going to be placed will be distally tilted. You need to pay more attention in free-end cases. How can we prevent tilting of the guide? In order to solve this problem, there are these anchor tools within the One Guide kit. There are 3 anchor screws, and there's also anchor driver to place the anchor screw. There's also anchor drill, which can make indentation in cortical bone within One Guide kit. You need to use these tools within the kit in order to fixate the template properly and place the implant in free end or full mouth cases. By doing this, you can place the implant in the intended area following the path. If there's very few remaining teeth, or if it is free end case as shown below, you need to use 3 anchor pin to fixate the template. On the other hand, if there's 1 tooth on the one side, on the front side, and there's no tooth on the distal side, you can use 1 or 2 anchor pin to fixate the template. You need to utilize anchor pins appropriately in order to minimize complications. In the anterior area, in upper or lower, if you're going to place the implant immediately, there can be deviation in drilling once again. Let's think of the biggest difference between One Guide kit and taper kit. When you do immediate placement in the upper or lower anterior area, you need side cutting drill, which can make indentation on the hard bone on the lingual or palatal side. However, in One Guide kit, there's no side cutting drill. Because there's a guide hole where drilling is made possible in the planned path, a side cutting drill is made unnecessary. What would you do in this instance? What if the one guide drill or initial drill comes across a hard lateral wall on the palatal side? If the apex side of the drill makes contact with the palatal wall first, then it will give indentation, and then one guide drills can go in and widen that. However, if the lateral side of the initial drill first makes contact with the palatal wall, what would happen? As you all know, in twisted drill, there's no cutting blade on the side. Then no cutting will be made. Palatal and lingual wall are very hard, therefore drill can slip. In extreme cases, guide can be tilted. If guide is fixated using anchor pin, it can fracture as well. In the case of upper or lower anterior, if the cortical bone on the palatal or lingual side is thick and the initial drill cannot progress, you cannot press it with excessive force. How will we overcome this? There's no side cutting drill within one guide kit. In order to overcome this issue, one guide path drill has been introduced. It's not included in the one guide kit, but if you buy this accessory kit, it'll be useful. Path drill looks like this. This is not taper drill, this is reverse taper drill. Apical side is more thicker than the top side. If it comes in contact with the hard palatal or lingual wall, it makes accurate indentation vertically, making notch and can cut through. When you use one guide template to do immediate implant placement, if the initial drill or one guide drill does not progress properly, it means that the lateral side is in contact with the palatal or lingual wall. Take out the drill and use one guide path drill sequentially and make indentation on the palatal or lingual wall, and then use one guide drill once again. Up until now, I talked about deviation in drilling related to free end cases where distal tilting occurs. If there's no residual teeth supporting the one guide template, the guide itself can be tilted, and in immediate implant placement cases in upper and lower anterior area, the lateral side of the drill can hit the lateral palatal or lingual wall, and consequently it can slip. Another major complication is thermal damage. This can be expressed as heating necrosis or thermal damage. When you drill using one guide template, compared with taper drilling, heat generation is higher because the one guide template itself obstructs irrigation. We need to know the symptoms of thermal damage in order to be able to respond to it. The most notable symptom of thermal damage or heating necrosis is chronic dull pain. After 1 or 2 weeks since surgery, if the patient continues to experience pain on the apex side of the implant placement site, like that of being poked with a needle, you need to take periapical view and check the apex side of the implant. The heat necrosis due to heat generation starts off in the apical side of the implant. The apical lesion is radiolucent here, and with time, it gradually moves towards the coronal side. Implant failure can occur, and it takes 4 to 6 weeks for implant failure to occur. Can we anticipate this? When you use guide to place implant, in planning stage, if you consider and think about the bone quality, I believe we'd be able to avoid these questions. Let me show you my case. This is a 71-year-old male patient in lower. Fixed prosthesis was the chief complaint. In the upper, denture was used and it wasn't really uncomfortable. In the lower, attempts were made to use RPD. However, the patient continued to express discomfort and wanted fixed prosthesis. I decided to make a new denture in the upper, and in lower, implants were to be placed for fixed prosthesis. This is pre-op image. One guide was planned. Planning was done. Guide was fabricated. 3 anchor pins were used to fixate the guide. In order to prevent any gap with the gingiva below, it was fixated tightly to minimize tilting. As planned, 6 implants were placed. I decided to keep number 44 because there was no major mobility. As anticipated, implants were placed nicely. After 3 weeks, the patient came back saying that the implant failed. This occurred after 3 weeks since surgery. Actually, since 2 weeks after the surgery, the patient continued to express that he was experiencing throbbing pain. This is a typical symptom of heating necrosis, and the implant fell off and the patient brought it. I took a panoramic image. Heating necrosis accompanies necrosis of residual bone around the implant, and in the number 44 mesial to the number 45 implant, there was extensive distal bone loss. And there was mobility in that tooth. I explained this to the patient, and number 44 was removed, and instead of number 45, I recommended placing implant in number 44 and decided to restore number 45 with Pontic. In other words, bridge. And the patient came to me and said that the right side was now better, but on the left side, the patient was now experiencing throbbing pain in the lower. I took a look at the panoramic image, and around number 34, there is an apical lesion. You can see the radiolucent lesion. That's when I thought in number 34, there is heating necrosis as well. But at the time, there was no mobility on the implant. I thought maybe it would be okay. So I used the prepared prosthesis and provide fixed prosthesis. 4 implants were used, and 5 weeks after surgery, fixed prosthesis was fabricated. Temporary prosthesis was delivered as shown. At 3rd week after surgery, number 45 fell off, and at the time, number 44 was extracted and implant was placed. At the time, the patient continued to express pain in number 34. If you look at the image at post-op 5 weeks after final prosthesis delivery, you can see that apical lesion is growing and is coming towards the coronal side. I thought I needed to do something. I removed the implant. The 7.0 diameter TS4 implant was placed, and I submerged it. Although 7.0 was placed on the apical area, you can see extensive bone defect. I believe that is heating necrosis. Number 34, that was problem. Number 36 was okay, but why just number 34? I reviewed the data when I planned the surgery. This is the planning data for number 34 and 36. Mandibular canal position, implant length, and buccal and lingual wall thickness around the implant. That's what I considered. I did not think about bone quality. Number 34, it's mostly cortical bone. It's D1 bone. Number 36, it was D2 bone. Therefore, the bone response was different, although the same torque was applied to place the implant and same drilling sequence was used. The bone response differed. This is post-op 12 weeks, and on number 3 and 6 on both sides, 4 implants were used to provide fixed temporary prosthesis, which is similar to all-in-4 method. And after 12 weeks, the patient expressed pain in number 46. It was one body and it was all connected. And in order to figure out why, I removed the prosthesis, and you can see here, number 46, there was mobility. Failure in osseointegration occurred. This is different from what I've shown you. Heating necrosis, there is apical lesion or there is extensive bone loss, but if severe occlusal force is applied or if occlusal adjustment was done inappropriately, there is no extensive bone destruction. I thought the reason why number 46 failed was because occlusal force was extensively applied excessively on that area. I felt exasperated. I thought the purpose of guide surgery was to make it simple and fast and make it more favorable for the patient, but it really did not. And that's why I really felt exasperated. I removed number 46 because there was mobility and it was not helpful in any way. I assumed that the occlusal force is going to be strong on right side and added one more implant in number 46 and 7. If one implant fails in all on 4, would all on 3 be possible? I do not think so. Theoretically, it may be possible, but I believe it is nothing on 3. You can do nothing on 3 implants for fixed prosthesis. Only 3 implants were successfully osseointegrated for this patient, and I just removed the abutment and used complete denture as temporary prosthesis. It was very difficult for the patient because the patient went through surgery multiple times and implant failed so many times. Cause of implant failure was due to bone necrosis because of thermal damage and failure of osseointegration due to failure in occlusal adjustment and a severe occlusal force. The patient suffered from multiple complications and complete denture was used as temporary prosthesis. The new implants placed later were all successfully osseointegrated, and this was the final prosthesis. First, I plan to use 6 implants to provide fixed prosthesis, but a total of 7 implants were placed and 3 implant failures were experienced by this patient. This is post-op 6 months. This is panoramic image after final prosthesis. On the left, there was a very severe vertical bone loss, but I did not do vertical augmentation. I just used guide and drilled up to the mandibular canal safely and placed a short implant. This is lateral view on both sides and occlusal view. The patient went through a very tumultuous experience but was very satisfied with the final result. This is 2 years after surgery and there's no marginal bone loss. This is the panoramic image in the 2nd year, and this is the follow-up. We talked about thermal damage in relation with guided surgery, and this occurs quite frequently. We need to think about the amount of heat that is generated on the bone depending on the length of the drill and irrigation. A lot of heat is going to be generated in D1 bone. What is interesting is which drill leads to more heat generation. Most heat is generated when diameter 2.0 drill is used. If you look at the tested data, 2.0 drill is used full depth first. Lance drill is used to mark the cortical bone 2 to 3 millimeters. 2.0 drill is used at full depth for the first time. When you use a 2.0 diameter drill, most heat is generated. If it is D1 bone, more heat is going to be caused yet some more. Therefore, you need to pay more attention in hard bone. If you anticipate it to be hard bone, you do not to use 2.0 millimeter drill full depths. Use a shorter drill, 6 millimeter, 7 millimeter, and 8.5, and then 10. Gradually increase the length of initial drill up to the point of the implant length in order to minimize heat generation. The drill size and the length can also affect the heat generation. The longer the drill, the amount of irrigation that reaches the apical side becomes less and more heat is generated. If you use long 2.0 millimeter drill, more heat can be caused. When you drill over 10 millimeter, it is known that significantly more heat is generated compared to 8.5. And it also can vary depending on irrigation, temperature of the saline, depending on whether it has been stored in room temperature or in refrigerator. It can also affect the amount of heat generated even when the same length drill is used. If the saline is going to be used in surgery, you need to restore the saline in refrigerator under 10 degrees. The cold saline will help with reducing thermal damage. Another strategy to reduce thermal damage is to utilize the hand of the assistant in guided surgery because in this case, retraction is not necessary. Drilling is done mostly through the guide, so I have the assistant use one hand for suction and the other one for additional irrigation. In other words, there's cold saline coming from the handpiece and additional cold saline coming from the assistant. I always do drilling with 2 irrigation lines on. When you use initial drill instead of 2.0 drill, you need to gradually progress. And you need to be very careful in D1 bone. This is the patient that was referred to me. One guide was used to place the implant, and after 4 weeks, you can see extensive bone loss and the implant failed. I requested for the data that was used for planning. In most cases, in lower premolar area, you can see D1 bone filled with cortical bone. In this case, if you drill conventional way and place the implant with excessive torque, heating necrosis or compression necrosis can occur. In order to minimize thermal damage, we need to consider the planned implant position angle and the thickness of residual bone, as well as the quality of the bone where implant is going to be placed. If we are to place implant in a D1 bone, a lot of heat is going to be caused. In OSSTEM, when you use one guide, lateral open hole type guide can be used as an option, and this will help in increasing the amount of irrigation to minimize thermal damage. Today we've talked about complications related to digital guided surgery. A lot of people just think of digital guided surgery as something that makes implant surgery more easy and swift. If you apply it well in good case, it can be so, but if the case is complicated and the bone quality the patient has is bad, you can experience complications that I've mentioned. If you understand the mechanism of these complications, you'll be able to apply digital guided surgery with minimal complications. In this lecture, I talked about complications related to digital guided surgery. I really love using one guide system and I use it very frequently. However, if you use this without sufficient knowledge, you would experience a lot of complications. And I experienced those complications myself as well. A lot of knowledge and experience on the part of surgeon is necessary to get a more predictable, stable, and satisfactory guided surgery result. Thank you for watching. Stay tuned for the next lecture.